Hi everyone. So I'm Miranda Bain. I'm a senior investigator at the Pandemic and Emergency Readiness Lab. I'm here with my colleague.
I'm Prissy Weberall. I'm the Deputy Director of the Pandemic and Emergency Readiness Lab.
And we have joining us today Nina Schwalbe, who is the MPH PhD, and she is the CEO of Spark Street Advisors and a senior scholar at Georgetown's O'Neill Institute for National and Global Health Law. She has held leadership roles at Gavi, the Vaccine Alliance, at UNICEF, and as director of USAID's COVID-19 Vaccine Access and Delivery Initiative. She recently announced her run as a Democrat for Congress in her hometown of New York. Nina, welcome.
Thank you very much. Very happy to be here.
Thank you so much for being here. I think we're going to get started with the Congress question to begin with. Why now? Why today? How did you go from being a kick-ass activist to a U.S. Congress candidate? We'd love to hear your journey.
Yeah, well, thank you again for that. So I think it's probably obvious to most people in the rest of the world that the U.S. is losing its democracy and the systems that keep it safe. And as a public health expert and advocate, I felt I needed to stand up for our work and for our democracy. We, as you know, in the U.S. about a year ago when President Trump took office, he really got rid of public health. He fired about 200,000 of our peers. The programs that he stopped have resulted in, BU did a study, which they published a couple of weeks ago, 750,000 lives lost and counting. And it was just time to say no. And I thought, and if we keep sending the same types of people to Washington that we've been sending, we'll have the same type of Washington. Public health is a great way of thinking about systems and how to fix systems. And I'm optimistic that if we bring that lens and we bring a social determinants lens to our work, we can fix those systems.
You're saying all of our favorite words.
It's funny when you're in, people are like, you can't say social determinants. I'm like, oh no, what do I say instead? But I think people understand it. And you've also probably been following our vaccine policy, which is last Friday. The head of the committee said in a personal statement, not yet official, but he was going to make the polio vaccine optional.
And a lot of the childhood vaccines in general.
Hepatitis B vaccine is now optional. So measles, he wants to make optional. You recently lost your elimination status here in Canada. We're about to lose it as well in the U.S.
Yeah. With everything going on with ICE and also activism emerging around that, vaccines, RFK, I mean, there's so much going on that is impacting the public health architecture in the US right now, and it's kind of being brought crashing down by the government itself. So where do we go from here? Is it salvageable?
It's absolutely salvageable, but we have an unaccountable government right now. I mean, we're in a situation where our government is shooting down civilians on the street in cold blood, and it's systemic now. It's not just, it wasn't a one-off error. It actually seems to be a policy. So the first thing we need to do is hold them accountable. We have a Congress which isn't doing its job. Congress appropriates money in the U.S., and then the government is supposed to spend that money in the way at which it was appropriated. And what happened last year is the government held on the money and spent it on other things. And I think Americans are getting mad, and it's good. It's good to see Americans getting mad. Last week, I was on a demonstration in the streets of New York, and there were thousands and thousands of people really getting mad. I think people have had it and they're ready for change. And so I'm optimistic that we can change things and that people are ready for a different type of America and to get rid of Mr. Trump. And my first thing I'm going to wear, my first day in Congress, I'm wearing the Impeach RFK T-shirt, and I'm not taking it off until we're done with that. The public health situation is bad and people don't realize it. My mentor used to say in public health that when public health is working, nobody notices. And when public health is broken, everybody notices. And we're really on the cusp of that point.
I think it's also the politicization of public health and how it's become so tribal. You mentioned earlier that just mentioning social determinants of health could potentially trigger some folks. I've heard from colleagues in the States that doing work on misinformation, for example, is also flagged. I'm curious as to how much of that is part of your campaign right now. How much of those words can you say? How are you shaping the way that you communicate public health so that more people can understand that it's above and beyond just politics? It's what shapes our society, right?
Well, for those people that know me, I don't normally censor myself too often. That's not really my MO. So I'm talking about it. I mean, we have hospitals now no longer providing gender affirming care. We've been disallowed, if we get federal funding, from saying the words diversity, equity, inclusion, or gender. I mean, gender. So, and you can't do any sort of public health work unless you focus on the most vulnerable and meet communities where they are. So there's no holding back, and we have to speak truth to power and fight it out. There are a lot of mincing of words, but that's not the candidate that I am right now. We have a big nurses strike right now in New York City. It's the longest ever nurses strike in the history of our city. They're not providing nurses with health insurance, and they're not providing with living wage or with reasonable work hours. So we're really at a crisis point. We're at a crisis point.
How are folks navigating that challenge of, these words that are now being banned from being discussed in a public health context, equity, gender, things that are so fundamental to how we understand the world and public health, certainly. So
Not as well as I'd like them to. I wish more people would stand up and just ignore it and fight back. We had there was a story in the newspaper today about one of the big universities in Texas just getting rid of its gender department and all of its DEI related classes. Some universities are fighting back and saying you're not going to touch us. A lot have acquiesced. One thing, I heard a very funny story the other day, which was somebody was putting through a grant through the way when you put in grants, I don't know if it happens here too, it goes through like a bot. It goes through a bot screening to make sure, the investigator has 12 years of experience or whatever. So they misspelled the word equity in the grant.
And it went through?
So it goes through the
people listening in. Here it is.
Yeah, I love that. I love that idea. But you can't do the work without talking about it, and people are being silenced. But not everybody. Not everybody. People are starting to speak up, and I think that the horrific events in Minnesota have gotten more people to realize that it's gone too far, and they need to speak up.
Just a small point on that, actually. I think a lot of the things that we're thinking about is the role of academia and academic institutions to speak up and to become activists, oftentimes when those things are not necessarily incentivized or even encouraged in academic settings. What would you say to that?
I have noticed that the sector is not speaking up. People are genuinely afraid. And I spoke with a colleague yesterday. I'll give you two examples who works for an NGO. And he said, look, I'd love to speak up, but they'll come after our NGO. And we still need to do our work and our services, even if it's below the radar. So I can't be as active. And it's the same in universities. I gave a lecture in a university I'm not going to name a couple of weeks ago, and the professor turned off the Zoom because they didn't want to be recorded in the conversation that we were having about the pandemic treaty. It wasn't like we were talking, I don't know, it's a pretty boring subject. I mean, I like it, and we'll talk about it later. But still, people are really afraid, and I think that's coming down. People are afraid to use their voice, and freedom of speech right now is not being protected. And the universities are coming down hard on them. And in public health, it's also complicated. It's not complicated. Public health is and should be political. It always was. That's how we got into this field. But people are forgetting that. And one of the other problems is that a lot of public health schools in the U.S. are tied to medical schools. That are tied to hospitals. And hospitals get a lot of their funding from reimbursement from federal government for different programs, Medicare, Medicaid, different types of social programs. And the U.S. government has said, if you over there in the School of Public Health or the School of Medicine use those words, we're going to cut your funding on the other side. So there's a lot of fear.
Understand.
And a lot of conflation of all sorts of different phobias with freedom of speech. And it's a messy time. But people are afraid. Not everybody, but a lot of people are afraid. And I think that's that's how totalitarianism starts. And I don't mean to be hyperbolic, or I don't know how you see it from here, but it really is the start of a totalitarian regime. And you notice that when academics and others are afraid to speak
To
up.
speak up. Yeah. Yeah.
To take a step back, we'll come back to this towards the end, but just to go back to the beginning with you, it seems reading about you like activism is really part of your DNA from your family. So I wanted to ask about how that influenced you growing up and your sort of journey towards being an activist.
I think I never had a good filter on questions. And I just asked them, and I was encouraged. I was brought up in two traditions, both Christianity and Judaism, that really encouraged asking questions. And so I was always encouraged to ask questions, even if they were uncomfortable. And so I think that was a good start to being an activist and not taking no for an answer.
And what drove you towards public health in particular?
I had studied in the early part of my career to be a Sovietologist, which is a word that isn't used anymore. And I couldn't get a job in the Soviet Union when I graduated from school, and I went to work in a refugee camp on the Thai-Lao border. And there was a measles outbreak in the camp, and there was a big fight about whether the population should be immunized or not, and kids were dying. And a lot of there was a fight about, was it our right? Whose right was it to immunize? And I thought, well, this is fascinating, this idea between collective responsibility and individual choice. And I guess you both work in vaccines. It continues to play out to this day. So I thought this is very kind of super interesting field, very complex. And I've been thinking about it more recently I think one of the things that's so cool about public health is you get to ask those huge existential questions, like about individual versus collective rights. And then you also have to do the detail, like keeping the vaccines cold so that they're effective. Mm-hmm. So it's a really great mix of philosophical, existential, and just day-to-day getting stuff done.
Shall we talk about COVID?
Everybody's favorite subject.
Yes, favorite subject. I know that you were in New York when the first wave of COVID happened, and New York was hit quite devastatingly.
Yeah.
I still remember seeing videos of that. What was the game changer for you seeing that in terms of how New York got hit? And do you think New York is better prepared today? And just some lessons that you learned or reflections that you have from that time?
I'm going to start with the second part. And I'm not going to say I tweeted about it, but I tweeted about it the other day. I was like, if we can't do the snowstorm, we're not going to do very well in the next pandemic. And I think about that every day. I climb over the mountain of snow to get out to the street. So, yeah. But in terms of COVID, in March 2020, my father was one of the first people to get COVID. And I took care of him alone. We couldn't get any services in. We had no palliative care. We had no oxygen, nothing. And the only thing he had when he died was me being there with him alone in his apartment. As you said, the city was shut down. It was a mess. So after that, I decided that I needed to take my global advocacy work home and fight. And I fought Albany to get ventilators down to the city. They had a huge storage of ventilators, and the then Governor Cuomo did not want to give us ventilators, even though he was sitting on them. I fought to keep kids in school. And I can go into more detail around that and what that meant. And then to get vaccines when we had vaccines distributed to the older, low-income residents in New York. And then after that, I was asked by the Biden administration to lead their global COVID-19 vaccine program, which distributed 500 million vaccines around the world.
Can you tell us a bit more about that program and how that played out, sort of what it was like being in the room in those discussions?
Yeah, so it was about 2 weeks into it was June, President Biden said, he did this we had this whole world of vaccine inequity, which we'll, I'm sure, talk about as well. And Biden, to his credit, said, we got to give away some vaccines. So he purchased 500 million vaccines, and then they realized they needed to distribute them. So within 2 weeks, I was in Washington, well, virtually, because nobody was there. I was in my living room virtually in Washington. And one of the first things I realized was we have 500 million vaccines and no syringes. And so because syringes are made primarily in low and middle income countries, they use a different kind of syringe, which is auto-disposable. So the needle retracts. It's different than what we use in the U.S. And it's auto-disabled syringes. And they're made in India and China. And everything was frozen. There was no shipping and no mass shipping. Think of all the things we couldn't get back then because all of the trade routes were stopped. Well, one of them was syringes. So there was a lot of logistics to do. So we got the State Department involved. We actually had our Secretary of State call the Prime Minister of India. It was like a big deal to try to get those syringes. China wasn't going to give us any, but we got them. We did end up getting them, and it was a lot of logistical challenges like that, really daily logistics. The White House was very involved. We had 14 calls a week with the White House. The National Security Council was involved, but it was a great group of people who really felt like this was the right thing to do, was to get those vaccines out as quickly as possible.
I'm reflecting on what you said earlier about the big existential questions and then the logistics of it. And I think this was a prime example of grappling with vaccine inequity and inequities while also dealing with syringes that are missing. But something else that I'm quite taken with was what you said earlier about bringing the fight back home domestically. Can you talk a little bit about the interconnectedness between domestic and global? Oftentimes when we work in global health, people think that it's something that happens elsewhere and that it doesn't affect us here at home. But it sounds like you've been working domestically, globally. Can you talk a little bit more about that?
Yeah, I think it's interesting in running for Congress. What I've realized is, New York is my home and I've lived there forever. I realized as part of this campaign that I was a sixth generation New Yorker,
Wow.
which I didn't even know was possible. My cousin was like, I said fifth, and my cousin's like, you're sixth. I was like, okay, fine. But I think that there are progressives. I think a lot of people that do work in global health also do work domestically.
Yeah.
And that's this community-based approaches, thinking about social determinants. And I think a lot of us do work that bridge both sides, and particularly in schools of public health, where people have a social justice lens on their work, and that is what public health is about. What I did realize, though, is that there are things that we have thought about and done better in global health than certainly our policymakers know. I think in terms of New York State, I'm lucky I live in a great state with a great city public health department and a great global public health department. State public health department. Both are really good. And a lot of those people have worked across domestic and international programs. But what I saw, for example, with the COVID vaccine is the way that it worked in New York City was they set up these huge distribution sites, like army sites and tents, they had them in baseball fields, which in our work isn't really a great way of delivering services, especially to older people or to marginalized people. It's a bit of a turnoff. And I think the stadiums is something that is a huge turnoff in terms of how stadiums have been used in genocide and mass murder. So anyway, but that wasn't happening there, of course. But this idea of bringing vaccines to the community, the policymakers just hadn't thought about it. And I thought that was so interesting because I can't imagine doing a program in Burkina Faso or Rwanda or Thailand or pretty much anywhere else in the world where they wouldn't have thought, okay, we have to bring these vaccines to the communities and do mobile distribution sites. And we weren't thinking that way at all. And we were sort of thinking if we build it, they will come, or that's what the policymakers were thinking. So I found it was really quite retro in terms of their approach to thinking about equity. Now, that wasn't the public health people. That was more of the politicians who I don't think were particularly listening to the public health people. But I think a lot of those community-based approaches, and that's one of the things I also want to bring to government. And in public health, we do a lot of work on community scorecards. So we have people rate the services that they're getting, and we bring policymakers together with them so they can say how policy is going. But that's not really part of the domestic cycle.
I'm curious just to push a little further on this theme, because you've worked, in this leadership role with USAID, so connected to the US government architecture, but then also places like Gavi and UN agencies, and how these different spaces kind of how you navigate them differently, or what differs about them in terms of developing a sort of strong global health architecture in which we can build sort of strong preparedness measures?
Yeah, they're all quite different. There's a line in Chekhov. Let me just get this right. No, it's in Anna Karenina. All happy families are alike, and each unhappy family is unhappy in its own way. And so they're all a little bit different, and they are all bureaucracies. I think Gavi and the Global Fund, when they started, were not. They really had a very different sort of ethos. And I was joking around that when I went to work for the UN, I would come home to my family. I'm like, it's such a bureaucracy. And they're like, what did you expect? Of course it's a bureaucracy. But there's a big reckoning now in the field, and I mean, those organizations have all been destroyed. And how they're going to reconstitute themselves and with each other, I don't know how that's going to work out. I think you're Canadian? Your prime minister said, there's going to be a new world order, and that's also going to affect health. The cultures are very different in how these places work. And I'm a little sad that America now is pulling out and won't benefit from learning from others, because I think that's been a great part of being part of the UN and other systems.
I think when we saw the American flag be dropped at the WHO, that was a very, very sad sight to see, for sure. And I think just reflecting on that, if there was one key thing in the current global health architecture that you would change, what would that be?
For me, it's not. In the pandemic treaty negotiations, in fact, I was quite glad that the Trump administration wasn't there, because they just would have been bothersome and stopped it from moving forward. Yeah. So for me, I'd actually rather not have them in the room. I was glad they didn't show up in the room. And one of the things that makes me sad now is we didn't pay our bills. That's just pathetic.
That's right.
That's pathetic. Yeah. We have to pay our bill before we leave the WHO, and that's, again, as Congresswoman, that is something I will strongly stand for. And Mr. Trump also recently pulled out of the UN itself, which is kind of odd. Nobody really noticed it. It didn't really make the news, but he pulled out of ECOSOC, which is one of the chambers of the UN, which he can't do by himself. When he pulled out 2 weeks ago or a couple of weeks ago, all these different agencies, one of them was ECOSOC, but that's a chamber of the United Nations. So you asked me, I just feel very sad that we're pulling out of the UN, because that's where we sit and talk, and it's not always easy and it's not always fun. And sometimes it's quite dull, but it's where we sit together with other countries and try to work things out. So I think it's all quite sad. And I'm sorry that, a couple of other things. I also worry about the conditionalities that we're imposing on our money. And it goes back a little bit to the universities. I wish more people would just say no and not accept those conditionalities. So do you know the Mexico City policy? You know what that is? So the Mexico City policy is a policy that says that if you're getting funding from the U.S. government, you cannot use that funding for any services related to abortion. And they've now expanded that through a State Department order, or I don't know what the proper term is, to say that if you're getting any money from the U.S. government, you can't use it for abortion. Okay, we don't like that, but we expected it. You can't use it for any diversity, equity, or gender programming. You're not eligible then for your U.S. funding, and you'll get it taken away. And people are agreeing. They are not fighting back. There was some press recently last week about Gavi, the Vaccine Alliance, where the Secretary of Health said, unless you agree to certain conditionalities around our support, we won't give you the money. And I'm glad Gavi said no. Now, Gavi's in a situation where the U.S. is about 15% of their financing. So it's not like the Global Fund where it's a much bigger percentage. But I hope the Global Fund pushes back, because how can you do HIV and tuberculosis work if you can't talk about transgender populations, or gender?
Or gender, yeah.
So, yeah. So it's worrisome, and I really hope people push back and other countries step up a bit.
I my dissertation was in part about reproductive justice policy making, and so, well aware of Mexico City policy and the repercussions of that. And I've even been wondering if there's something to be learned within the wider public health community from the sort of sexual and reproductive health and rights community, because it's sort of always been on the fringes in that way. But I'm curious with all this defunding that's going on within the UN, how do you see the future of it? And also, is there anything do you see any opportunities there in terms of the future of the UN with everything that's happening right now?
There's a lot of pressure in our circles to talk about the opportunities, but I don't see any opportunities. I just see this as massive, malicious destruction. And a lot of things don't work perfectly. Nothing really works perfectly. But this is just malicious destruction. And 750,000 people have died. There's no opportunity in that. And we're denying people gender-affirming care. We're denying people pre-exposure prophylaxis for HIV. All of these proven effective hepatitis B vaccines, proven effective interventions being denied to people is just pure and simple human rights abuse.
Do you think there's a way, a lot of the conversations or dialogues that I've heard is, maybe after this administration, we can go back to where we were. And sometimes I think about the massive dismantling of the infrastructure and that's occurring. Do you think there's a way for us to go back or to rebuild, or where do we go from here?
We have to stop the destruction immediately. It just has to stop, because it gets worse and worse every day. I mean, you talk to your friends at the CDC and there are no measles people, or there's nobody staffing the level 5 lab. It just gets worse and worse every day. You hear worse and worse news. And then we have to put back a system focusing first on the immediate and urgent needs, which is also infectious disease surveillance and pandemic preparedness and response. We have to stop, and then we have to restart. I think we have to restart. It's going to be very hard to. I don't know. You guys have both been bosses. It's very easy to fire people, and it takes a long time to hire people. I mean, particularly in the U.S., where we don't have a lot of protections for workers. But it's going to take a long time to do it. And I also worry. I think in my role at Georgetown, we're seeing less students want to go into these fields because it's not a stable field. And in the U.S. as well, they've decided that there's no more loan reimbursement for a bunch of health professionals. There used to be loan forgiveness programs for health professionals, and now a whole bunch of categories like nurse practitioner and nurse and public health, they no longer count. So we just have to stop this right now, and then really double down on investing in building it back up. One of the things that I think we can do immediately is investment in primary health care. Despite what you hear about America, there's a reasonable primary health care system, which is federally funded. And that's a program where we can immediately double down, increase funding, and bring up our coverage on primary health care. But it's just got to stop and start again.
Shifting gears to think about some of these sort of specific pandemic discussions that you've been involved with. Firstly, just thank you for keeping the world updated on the pandemic treaty negotiations. I mean, truly amazing and essential work for all of us working in this space. The pandemic access and benefit sharing, can you talk a little bit about that, sort of why it's important? Do you think we're going to come to an agreement?
Yes. And thank you for saying that, because it was a lot of UN meetings to listen to and pay attention to. So the point of the pandemic, the PABS, the pathogen access and benefit, it's a pretty simple idea. It's that if you share genetic materials, then the products that are developed with those materials have to be shared back with you. And that is exactly what didn't happen during COVID. And the classic example that's used is the Omicron variant, where South Africa said we have a new variant. We shared it, they shared it, and we said, thank you very much. We're going to make a new vaccine and you can't have any. And not only that, but we're going to close the borders so you can't travel. And I think that that's really the typical, that typifies why we need this. So last year, the world, with the exception of a couple of countries, just a few, came to an agreement on the pandemic treaty, One Health, so the zoonotic environmental people circle of infections, on financing, on regulatory, on a whole bunch of issues. But the area where they couldn't reach agreement was on pathogen access and benefit sharing. They couldn't get agreement between the North and the South about what happens if the Global South gives genetic information or other information, and what's the obligation of the Global North or the pharmaceutical manufacturing countries to give back. And that's what they are now, and they're kind of stuck. And they don't have very much time to negotiate it because the World Health Organization adopted the treaty last year, except for this annex, and they gave the negotiators 1 year to come back with the annex. And that year runs out pretty soon. We're almost there. I think there are 10 negotiating days left, and they're just not even close to far enough. They're locked between still the same issue that blocked them over the last couple of years, which is we have the manufacturing countries on one side, which is mostly the global north, but not only, and we have low-income countries on the other.
And what would that mean that we don't meet the deadline?
It would mean that the treaty would go on indefinite hold, or the World Health Assembly could extend the negotiations for another year. But I think they'll probably just put a pin in it.
On hold for an indeterminate period of time.
Probably until kind of the world order changes a bit.
Wow.
Because if they haven't, let's see, they have 10 more days to do it. One of the things that's been really disappointing is that our think tank is an observer to the process, and we haven't been allowed to observe this time. So we've had even less access. Before, in the first years of negotiating the pandemic, we had limited access, which increased over time. And this set of negotiations, which started in September, member states had agreed that these stakeholders could be in the room and listen to the negotiations, because we're also experts and can help explain and smooth things out and just help as part of an inclusive stakeholder process. But some member states did not want civil society or others in the room, and we've been given no access to the negotiating. So we don't really know what's being said, and that makes it much harder to comment or to be helpful. But because when the annex is a necessary part of the treaty can't be completed without this annex on pathogen access and benefit sharing. Sadly.
Shifting to think about immunization and vaccine delivery, and sort of touching on our earlier conversation about equity. So you're a huge activist for vaccine equity. What do you hope for now in terms of achieving or making progress towards that goal?
We first have to impeach RFK Jr. He's a big problem on that front. And there has been a lot of good work on diversifying manufacturing. And I think one of the big reckonings of the last few years is that markets will solve social problems. So in the 80s, 90s, that was big. Like, if we just let the market work, the market will solve these huge intractable social problems. And I think we've seen time and time again that doesn't help in housing. It doesn't help in health. It really hasn't helped. And that was very much the mantra of vaccines, making markets work for vaccines. And in fact, Michael Kremer won a Nobel Prize based on making markets work for vaccines on that premise. But it didn't really work. It isn't really working. And we saw that during COVID. So one of the great things has been the focus on regional manufacturing, and this idea that it's okay if it's a little bit more expensive is fair, and that's good. It's not all about economies of scale, because if you have only focus on economies of scale, you end up with either monopolies or oligopolies. So that was good, but we're really in a problem with our government, my government, not your government, my government right now, because we're really dissing the science. Yep. And one of the big innovations there is the mRNA vaccines, because they're cheaper and easier to do, and it's a lot more flexibility. There's a lot of like huge pluses, but we've just basically defunded that. And not only have we defunded it, but we're calling it my government is calling it like bunk science, which doesn't help because people have always been hesitant about vaccines. That's not new. It's the scale of it that's just out of control right now. And I, again, just wish more people would stand up and say, and we have you're interviewing one of the greats this week with Dr. Osterhoff. But I wish more people would stand up for this and stand up for science.
I want to touch upon the last piece that you talked about, all the confusion that's created with the constant changes by the administration and who they should listen to. You have the American Pediatrics Association saying stick with the schedule, and then you have all of this confusion and doubt that's created intentionally by members of the administration. How do we get back that trust that's lost from all of this chaos that's been created in that information ecosystem with regards to vaccines in particular?
We have to get this government out of office, and we have to restore our CDC. And I'm confident that when our CDC is restored, that people will listen to it. He has sowed a huge amount of doubt, and I'm sure you've been reading the news to say that parents are confused, and kind of rightly so, because they don't know what to do. And then a lot of doctor time or nurse practitioner time is spent on this issue, which shouldn't be an issue. But the first thing that needs to happen is to restore our CDC. And once we've done that, I think we'll be back on track.
Mm-hmm. I guess our next question follows up with that, is just how do you navigate these political contexts that in a context that doesn't even want to recognize words like equity, words like vaccines, words like mRNA. I think there are certain states that are completely banning the word or whatnot, when there's so much potential for not just vaccines, but also therapeutics, right, for mRNA. And that's such a loss, not just for the US, but also globally with regards to R&D and this scientific progress. And the really helpful human outputs that would have come out of that, or outcomes that could have come out of that. So how are you planning to navigate this political context, given your background? I will be
the only PhD, Democratic public health PhD in Congress.
Wow.
And I think that just speaks to we need more of us there, and we need more of us in leadership roles, because we have the expertise and we know the science and we know the evidence, and that's in our realm, and we should be more active in the political space. And I think once we are, we have the opportunity to change it. Because a lot of people, I mean, if you're just talking from your talking points, how are you going to really know how to question? And that goes back to the activism. I mean, you have to have some knowledge of the subject in order to really question people who are being approved for positions like the head of the NIH or the head of the CDC or the head of Health and Human Services. I think we need more PhDs in public health and more public health people to take office and to move into government.
Why do you think there haven't been so many present or sort of making that connection to actually going into government up to this point?
I think, well, I mean, I don't know. That's a really great question. I'm curious to know what you think, if I can ask you. I have one idea, but maybe I'll ask you back.
Well, I mean, it's something we've sort of spoken about a bit before in terms of I don't know, I'm more of a policy person in a way than having really granular technical expertise in health or science. And so I feel like there's sort of a focus on producing the evidence, basically. And if I have the evidence, then it will be listened to. And I think, obviously, that has been debunked in recent years, but maybe it's still such a recent sort of phenomenon in terms of how widespread that questioning is, that there's still a bit of catching up to do in terms of recognizing that, we actually have to kind of advocate for what we're discovering here and what the evidence is saying.
I would add to that too and say, I think a lot of the times those of us who have a PhD have been trained on neutrality, right? Of the idea that, as Miranda said, evidence is enough and that we have to be not political, which is kind of laughable when you think about the history of public health and how it
Yeah.
emerged. So I think because we're not trained in it, we just, crunch up the data. As an epidemiologist, a lot of it is just, crunching up the data and saying, okay, here it is, and this is enough, not thinking that, when we design the study, when we think about biases, all of that also is part of activism, right? Who you choose to study, what is being
That's
studied
right.
is a decision that you're making. So everything that we do is political. But I
Yeah.
also think on the flip side, it's scary too. For those of us who did science communications during the pandemic, the amount of vitriol that you got, especially if you were a woman,
Yeah.
and the gendered aspect of the type of attacks that you would get. On one hand, you want to be public, you want to speak up, but on the other hand, if your funding is associated with that, your jobs are associated with that, and then you're also getting threats, it's a lot, I think, to ask for everybody, especially those who are vulnerable, to take up more of a political public figure space.
I think both of those are absolutely straight on. I think a lot of people that go into public health too, it's a silent profession. We do stuff so that everybody else can not get sick, and we're happy with that. That no, as sort of what we talked about before, when it's working, nobody knows who you
Nothing
are,
happens.
and when it's not, everybody's angry at you. But most of the time, for what we do, it's working, and we're all happy. We don't really need those accolades behind us. I think on the one thing that we need to do better is how we talk about risk. We're really still very bad at talking about risk, and I think as public health people too, Dr. Brian Wall and I talk a lot about this. He's a professor at Yale, and one of my collaborators is, we'll give the findings, and then we'll have 3 paragraphs about the biases and the this and the that, the limitations, and we sort of, like, normal people have no idea what we're talking about at the end of the day, and we just have to just be okay to say it as straight out as possible, and we always feel the need, I think, to caveat in some ways, and it's funny. Even I've thought a lot about statistics and Popper and the way that we have to describe the null hypothesis. There's, it's just not, it doesn't build confidence if you say it in that way. There's less than a 0.05% chance that what you're doing is random. Well, that's not very confidence building. So I think there's a way we need to just be more confident, because people are looking to us to be confident. And that's why I'm also confident that we will rebuild our CDC, or we still have a CDC. We'll put people in there, and people are looking to them for confidence in guidance.
Yeah. I think one thing that I was reflecting on while you were speaking about all of this is I think we often hear about the big health emergencies, COVID, what's happening right now. Is there a crisis that you think isn't getting the attention that it deserves right now, whether it's in public health or more broadly?
Oh, that's a very difficult question, because I think no health crisis is getting the attention that it deserves, probably. And we have so many epidemics in the U.S. and globally right now. I think we have a mental health crisis. We still have a TB crisis. It's still the leading infectious killer of adults globally, and we haven't done really anything about that. We are going to see again a burgeoning HIV crisis. We have so much. And now we have measles. I don't even know, where do we begin?
Yeah. I mean, sort of following on from that, I was going to ask you about, so we're hoping that our students will be listening to this podcast, and I think it's a very overwhelming time in terms of just where we're at in the world. And so you've been so vocal and articulate about injustice throughout your career. Do you have advice for students and anyone who's wanting to sort of get involved in activism and get their voice heard? What would you suggest?
100%. Just use your voice. Speak truth to power. We all just wherever you can nudge people and be annoying and do it. And I was, one of the things about politics I'm realizing is that there's some cocktail parties, and generally we're pretty we're not good at cocktail parties. We talk about death and disease and dying and
Public health restrictions.
Yeah.
exactly all these things.
Seatbelt.
Nobody wants to talk about how many drinks are you having?
Yeah.
You shouldn't be. But I think just use your voice and let people know we have to do it. We have to shout it. We have to shout it. Vaccines work. Everything we have to shout it. Naloxone, harm reduction, needle exchange, PrEP. Just pick it and go for it because people don't know it because it's been working. And so it's our responsibility to speak out. And the other thing I think for students is, I also think we absolutely have to stay true to evidence, and that's our role. And so just make sure that you're speaking from evidence to the best evidence that's available. It's not always available, but as long as we're solid on the evidence.
Yeah, I would say just to your last point, I think just showing the successes of public health is something that maybe we're not as good at.
That's a great point.
Just the day-to-day wins of having clean water here, in certain parts of Canada and in the U.S., and just the fact that our roads are safer.
It's not all over Canada?
I mean, we have a whole northern situation.
Okay.
So just focusing on the wins of public health, I think would probably change the way that folks view public health, because oftentimes I think they think of public health and they think of masks and crises and restrictions and shutdowns, and so maybe there's some work to be done there as well.
I love that. We'll
Yeah.
talk about seatbelts.
Yeah, seatbelts.
I love that. And traffic lights.
Traffic lights. There you go.
Yeah, no, I love that.
You do all this amazing work. You just listening to you over this conversation, you're so busy. And I know also from looking at your campaign page, you said you're a dance mom and you're an advocate in your community. What do you do to relax? What do you do to
Sustain
chill?
energy.
Yeah.
Well, when I was really chilling, I got a PhD.
Oh, come on.
I like to. I like to goof around with my kids who are adults. That's my favorite goof around.
Yeah.
And play Uno. I like to play Uno.
Amazing.
All right. Well, thank you guys very much.
Thank
Thanks
you
for
so
this.
much.
Really nice to
Thank you
talk
for
to you.
being the voice of public health in a very,
Yes.
very trying political time. Thank you.
Yes.
We're trying. Thank you guys. Thanks very much.